Welcome. In this session, we are going to start our discussion on malignant eyelid tumors, and we are going to discuss them in two parts. In this part, we are going to discuss basal cell carcinoma and squamous cell carcinoma. And in the next session, we are going to discuss sebaceous gland carcinoma and malignant melanoma, as well as a few other rarer tumors. Now, malignant eyelid tumors in general have certain common risk factors such as fair skin, sun exposure, exposure to ionizing radiations, smoking, previous history of skin cancer, and immunosuppression. There are certain features which suggest that the lesion might be malignant, and these features include painless growth for several weeks to months, a chronic non-healing ulcer with bleeding, crusting, and discharge with a pearly translucent margin. For non-ulcerated lesion, we will find overlying fine telangiectatic blood vessels. Madarosis or loss of eyelashes is a very important sign to look for, which suggests the lesion might be malignant. Destruction of eyelid margin anatomy, particularly effacement of meibomian gland openings, and loss of skin wrinkles or vellus hairs. For pigmented lesions, signs suggestive of malignancy include irregular border, asymmetric shape, irregular pigmentation, and recent change in pigmentation. So here we see irregular border, asymmetric shape, and variable pigmentation. This graphical picture shows that when the lesion has a uniform pigmentation, a symmetrical shape, and a regular border, it is usually likely to be benign in nature. But when the shape becomes asymmetric, the outlines become irregular, the pigmentation becomes variable, or the size becomes larger, the chances are that the lesion is malignant. Clinical features which suggest that the lesion is malignant and is in an advanced stage include adhesion of the lesion to deeper tissues or bone, involvement of the puncta and canaliculi, restriction of eye movement or proptosis which suggests orbit invasion, loss of function of the fifth cranial and the seventh cranial nerve which occurs with perineural spread characteristic of tumors like squamous cell carcinoma, regional lymph node involvement, particularly the preauricular and the submandibular lymph nodes, and presence of systemic metastasis which should actually be searched for in tumors such as sebaceous gland carcinoma and malignant melanoma, which are known to be invasive. Any suspected malignancy requires a biopsy before a major definitive resection and reconstructive surgery is planned. And a biopsy is appropriate when it is representative of the lesion clinically, is large enough, is not damaged by crushing or cautery, and includes normal tissue beyond the margin of the clinically visible lesion. Photographic documentation of the lesion before biopsy is taken is recommended. The biopsy can be either incisional or excisional. In an incisional biopsy, only a part of the tumor is removed, and an incisional biopsy is indicated when the tumor is large and involves the eyelid margin or the canthi. In an excisional biopsy, an attempt is made to remove the entire tumor and is indicated when the tumor is small or is located away from the eyelid margin or canthi. During an excisional biopsy, histological control of the margins of the tumor is important to ensure that the margins of the biopsied area is tumor-free, and this can be done with either the Mohs technique or by frozen section biopsy. In the Mohs biopsy technique, we ultimately get horizontal sections of the tissue along these planes on the histopathology slide. So in one slide, we can see large portions of the tumor margins. Whereas in frozen section biopsy, we get vertical sections of the tissue on the histopathology slide. So only a limited extent of the margins of the tumor is visible on one slide. Incisions for the biopsy, whether incisional or excisional, should be vertical to minimize eyelid retraction and entropion following closure of the wound. Basal cell carcinoma is the most common eyelid malignancy, constituting 90 to 95% of all eyelid malignancies. It arises from cells in the basal layer of the epidermis and most frequently occurs near the medial canthus and in the lower eyelid. Basal cell carcinoma, like most other eyelid malignancies, occurs in middle-aged to elderly patients. Risk factors for basal cell carcinoma include fair skin, prolonged sun exposure, particularly early in life, cigarette smoking, arsenic toxicity, exposure to ionizing radiation, scarring in the skin, and patients with a previous history of BCC are likely to have BCC again. Multiple BCC lesions can occur in younger individuals in two situations: basal cell nevus syndrome and xeroderma pigmentosum. Basal cell nevus syndrome is inherited in an autosomal dominant manner, and patients with Gorlin-Gall syndrome have multiple nevoid BCCs occurring early in life, as seen here in this picture. They also have keratocystic odontogenic tumors occurring in the gums, as well as pits in the palms and the soles, as seen here in the picture. Skeletal anomalies such as bifid ribs also occur in basal cell nevus syndrome. Xeroderma pigmentosum is inherited in an autosomal recessive manner and is characterized by defective DNA repair mechanism of UV or sunlight-induced skin damage. The morphologic types of BCC found clinically include nodular BCC, nodulo-ulcerative BCC, morphiform or sclerosing BCC, and pigmented BCC. In nodular BCC, as seen here in this picture, the lesion appears as a firm, raised pearly or pink nodule, often with surface telangiectasia. In nodulo-ulcerative BCC, also called a rodent ulcer, we find a central ulceration surrounded by a raised rolled margin. In morphiform or sclerosing BCC, which is a more aggressive BCC likely to involve dermis deeply, we get a flat, indurated yellowish to pinkish plaque with indistinct margins. As seen here in this picture, being less elevated, it is more difficult to detect, and morphiform or sclerosing BCC usually occurs near the medial canthus with a higher potential to invade the orbit and paranasal sinuses. Morphiform BCC can also present as chronic blepharitis with metadosis, which can also be seen in sebaceous gland carcinoma, as we will be discussing in the next session. Pigmented BCC is clinically similar to the nodulo-ulcerative type of BCC with brown or black pigmentation. It resembles a malignant melanoma of the eyelid, but is more common than a malignant melanoma in the eyelid. For diagnosis, a biopsy is required, either excisional or incisional, and when an excisional biopsy is performed, the Mohs technique is preferred, as we have discussed earlier in this session. On histopathological examination, the most common form of BCC found is undifferentiated BCC, which in the clinically nodular BCC shows nests of basal cells originating from the basal layer of the epidermis with peripheral palisading within the cell nests and retraction of the stroma away from these cell nests. And in the clinically morphiform BCC, histopathology shows cords of cells as seen here with surrounding fibrosis instead of peripheral palisading. The common differentiated forms of BCC are the adenomatous and the basosquamous BCC. In adenomatous BCC, the basaloid cells are arranged in pseudoglandular patterns, and in basosquamous BCC, we get both basal cell carcinoma and squamous cell carcinoma components, and basosquamous lesions are known to be very aggressive. In doubtful situations, immunohistochemistry may help us in identifying the lesion, and basal cell carcinomas are positive for BER-EP4 antigen but negative for epithelial membrane antigen. For basal cell carcinoma, surgical removal is preferred because surgical removal has a lower recurrence rate and a better cosmetic outcome. And during surgical removal, the entire tumor is removed with 1 to 2 millimeters of surrounding normal tissue. Following resection of the tumor, reconstruction of the eyelid is undertaken after ensuring complete clearance of the margins histologically, and this reconstruction should be done as early as possible. If the reconstruction cannot be done immediately, the cornea needs protection with patching. Medial canthal tumors may require removal of the lacrimal apparatus, and reconstruction of the lacrimal apparatus is undertaken only after ensuring that the patient is tumor-free. If basal cell carcinoma invades the orbit, exenteration is indicated. During excision biopsy or during the definitive resection of the tumor, Mohs micrographic surgery provides the highest cure rate with histologic control of margins, as we have seen, while minimizing the removal of normal tissue. The Mohs technique is indicated in morphiform tumors, medial canthal tumors, deeply infiltrating tumors, and recurrent tumors. But tumor margins invading orbital fat may not be amenable to Mohs technique of histological control of tumor margins. And Mohs technique requires collaboration of ophthalmologist with a Mohs surgeon. Cryotherapy is indicated for poor surgical candidates, and cryotherapy has a higher rate of recurrence of the tumor as compared to the recurrence rate following surgical removal. And the recurrence rate is higher for morphiform lesions, medial canthal lesions, lesion size more than 10 millimeters, and recurrent lesions. Of course, cryotherapy does not allow histologic control of margins as to surgical excision, and cryotherapy can cause depigmentation and atrophy of the skin, notching of the lid margins, and symblepharon. Radiation is also indicated for poor surgical candidates and has a higher rate of recurrence as compared to the recurrence rate following surgery. And recurrence following radiation therapy is difficult to detect, occurs late, and surgical removal of the recurrent tumor is difficult because of radiation-induced tissue changes. Like cryotherapy, radiation therapy also does not allow histologic control of margins, and radiation therapy is contraindicated for medial canthal lesions, particularly the morphiform type, because of an even higher rate of recurrence. Radiation therapy is also contraindicated in Gorlin-Gall syndrome and in patients with immunosuppression. And radiation in the periorbital area can cause cicatricial lead changes, keratitis sicca, lacrimal duct scarring, ocular damage, and radiation-induced malignancy. Chemotherapy is also an option for poor surgical candidates, and chemotherapy can be given topically with imiquimod or 5-fluorouracil. Photodynamic therapy with methyl aminolevulunate is an option for patients with multiple lesions such as is found in Gorlin-Gall syndrome. Systemic chemotherapy is indicated for orbital involvement which is not amenable to surgery or radiation. And options for systemic chemotherapy for basal cell carcinoma include oral vismodegib and sonidegib. Basal cell carcinomas rarely metastasizes to distant sites but can be very destructive locally, and this is very important to remember. And the recurrences following excision of the primary tumor are more infiltrative and destructive than the primary tumor itself. Overall mortality rate from BCC is low at 3%, and this is usually due to orbital or intracranial invasion. So mortality from BCC is due to local invasion and not distant metastasis. And the risk of mortality increases with medial canthal tumors, morphiform tumors, perineural spread, neglected tumors, and tumors occurring after prior radiation therapy. Squamous cell carcinoma or SCC is the second most common malignant tumor of the eyelid and constitutes 5 to 10% of all malignant eyelid tumors, so it is far less common than basal cell carcinoma in the eyelid. The tumor cells of squamous cell carcinoma arises from the stratum spinosum or the squamous layer of the epidermis. And squamous cell carcinoma can occur de novo, that is without a pre-existing lesion, or can occur in areas of sunburn and actinic keratosis, which we have discussed in a previous session. Squamous cell carcinoma is more aggressive than BCC and can spread locally, which is often perineural in character as well as through lymphatics and hematogenously. Risk factors for squamous cell carcinoma are numerous and include UV radiation, fair skin, human papillomavirus infection, exposure to ionizing radiation, arsenic toxicity, psoralen therapy for psoriasis, scarring of the skin, xeroderma pigmentosum, albinism, and immunosuppression. And squamous cell carcinoma is known to be the most common malignancy after a solid organ transplantation. Like basal cell carcinoma, in the periocular region, squamous cell carcinoma most commonly arises in the lower eyelid and near the medial canthus. However, in the upper eyelid and near the lateral canthal area, squamous cell carcinoma is more common than basal cell carcinoma. And clinically, squamous cell carcinoma appears as a nodule or plaque which appears erythematous, indurated, and hyperkeratotic, having irregularly defined margins with or without central ulceration. On histopathological examination, squamous cell carcinoma shows polygonal cells with eosinophilic cytoplasm, hyperchromatic nuclei, and mitotic figures. This keratosis or occurrence of keratin beneath the stratum granulosum, in the stratum spinosum, or in the basal cell layer of the epidermis is also found in squamous cell carcinoma. Keratin pearls, as seen here in this picture, and intercellular bridges between the cells of the squamous cell carcinoma are also found, but keratin pearls and intercellular bridges are few or absent in poorly differentiated squamous cell carcinoma. And on immunohistochemistry, unlike BCC, SCC is negative for BER-EP4 but is positive for epithelial membrane antigen. Management of SCC is similar to BCC by biopsy followed by excision by frozen section or Mohs technique for histological control of the tumor margins. We will be discussing sebaceous gland carcinoma, malignant melanoma, Kaposi's sarcoma, and Merkel cell carcinoma in the next session. Thank you for listening.